My name is Ioana Datcu. Thank you, Ele, for the wonderful presentation. And thank you, B&B, again, for the invitation. For me, again, it's an honor to be here today. And well, it's a pleasure to be here again today, because I started, as Ele said, with B&B Dental family, because it was a family history. My father's works with Simone's fathers, Claudio Banzi, that I thank. That's why we start together and share together our passion for our daily routine approach, and try to introduce new protocols and techniques in our dental routines. So today I will talk about the digital approach in a clinical daily routine. But first of all, as Ele said, I start to work with B&B Dental, I think now is 8 years ago, from the beginning that I start to use my first implant. And I am part of different society and different digital protocols. And I come from Ravenna. Ravenna is a city near from Bologna, 1 hour far from here, that is famous for mosaics Byzantium, where I start to grow and create my dental routine in this small clinic, and where every day I try to introduce new protocols, new digital protocols, in order to increase the predictability of my workflow. And I would like to start with them. These are my top models patients that every day came in my clinic, and they ask me simple questions. They want to eat. So we know from the beginning that we have in front of us a new modification, a new transformation, not only of their smile, but completely, we can transform completely their face. Because we can change their smile, but we also increase their acceptance and their compliance in themselves, but also in ourselves. So my daily approach and my goal, and should be our goals, is that we have, especially for immediate loading protocols in a full arch rehabilitation, to try to combine the nice soft tissue contour around our prosthetic full mouth rehabilitation. Not only for an aesthetic point of view, and also for a functional point of view, but also for a maintenance in time. So we have to give our patient the possibility to clean well around our implant for a long-lasting stability. And for doing this, every day I introduce all my dedication, all my inspiration, protocols, passion, but we need to, in order to create this kind of results, we need a team. And we need protocol. Whatever you want to perform, especially in a complex case rehabilitation, all on 4, all on 6, you need a protocol in order to increase the predictability of your dental outcome. So let's see how today, with the new technology, we can afford this digital revolution in our daily practice routine. And the question is, where, when, and how this new technology can be incorporated in our traditional daily practice, and which kind of benefits this new technology can give us, and how they can change our working process passages, our dental technician working process passages, for better increase our diagnostic approach, but also the predictability of our treatment planning. So, I would like to show you with this presentation which is my learning curve and which was my learning curve in this digital revolution. But first of all, I like to respond simple question. Why? Why we have to start thinking digital? First of all, we can decrease the cost and decrease the time for us and for our patient, and maintain the same quality, even if at the beginning we have to afford a learning curve and we have to afford more cost to invest in the new technology. Thanks to protocols, we can standardize and simplify even every procedure in order to increase our efficacy and our efficiency. But of course, again, we need a dental team. Then we need also dental company, implant company that support us with this new digital revolution. So the real dental revolution starts especially about 10 years ago by the introduction of the digital procedure, the introduction of intraoral scanner, but also 3D implant planning softwares that give us the possibility to perform less invasive treatment plan, less invasive surgery, and perform a more predictable aesthetic result and function result, especially in immediate loading protocols. So, first of all, it's important to understand that the most important acquisition is in this digital workflow is that we have the possibility to increase our diagnostic approach from the beginning. And doing this, we can be more accurate. For example, with the CBCT and intraoral scanner, we can acquire data in a more accurate way. Then, with all this information, we can use them in the 3D implant planning softwares on a computer monitor. We can integrate all this data and create and obtain a 3D virtual model of our patient where to start planning virtually our implant planification. Then, again, with only a click from the second step, that is the data elaboration, we can send all these files to the third step to create our final restoration or our surgical template that give us the possibility to perform a guided surgery protocol. So, our goal is to create in our daily routine and to perform in our daily routine a complete digital workflow. In this complete digital workflow that starts with the intraoral scanner, with the CBCT acquisition, what we have inside the wire that combine all the steps in this complete digital environment are files. So this is our way of changing thinking. Because in order to create a 3D virtual patient, we need to combine different information that we can acquire for different CAD situations. So we can obtain the STL files from the intraoral scanner, for example. We can obtain DICOM data files from the CBCT acquisition, but also OBG and integrate with a facial scanner and combine everything with photography. But let's see, what is new? Until now, in order to obtain these STL files, what we did, we could took a normal impression, then scan the models, and thanks to the CAD softwares, obtain these STL files. So we have the traditional way to obtain the STL files, And then, today, by the introduction of the intraoral scanner, we have the possibility to obtain directly these STL files, avoiding the traditional impression, avoiding the traditional variables that are involved in the traditional impression, creating the models, the material variables, and obtain the STL files ready to be sent to our dental technician lab. So nothing new. This is important to take care of, that STL files, that means the standard triangulation languages, that is the common universal way of describing a 3D geometry of an object. We can use it and found it in all these different situations. So STL files from the CBCT, from the CAD softwares, from the milling machine, from the 3D printing. So digital workflow means combining from the CAD acquisition of the files, CAD elaboration, and CAM manufacturing products. So all this digital technology, it is functioned thanks to the CAD-CAM technology. So let's see which are the B&B Dental digital prosthetic solution. So how can we consider a digital complete workflow with the B&B Dental products? And we all know that we, first of all, in implantology, we start for choosing a proper implant for the more suitable surgical anatomical solution. So we have different options, implant surfaces. Then, let's see what is new also from the digital point of view. Nothing new. In the traditional way to take an impression, in an analogic way, we had the pick-up transfer for the implant solution, and we have pick-up transfer for the multi-unit solution. At the same time, in the digital approach, we will have a scan body for the implant. We will have a scan post with a CEREC base if you want to use in a CEREC environment. We can have also a scan post for the T-base and a multi-unit scan for a multi-unit. So nothing new, the same procedure, different way to take the impression, but the same prosthetic solution. The difference that we can say that we have is only for the analog, because of the shape, because of the geometry. For the digital analog that we have also for the implant solution and for the multi-unit solution, we only the problem is that we have to remove this analog from the 3D printed model. This is the only difference. But as you can see, is the same. So, as for the traditional way of taking our impression, you are aware how to do it, and the protocol is always the same. So we can either take a normal impression or an intraoral scanner impression, and how we can match this with the digital laboratory steps. By the library. In all CAD softwares that are used by the dental technician, ExoCAD, 3Shape, there is a B&B Dental library where we have the possibility to match the information of our scan body and start the creation of our final rehabilitation. So, as I said, nothing new under the sun. The most important thing is the best fit between the scan body, even if you use it on the model, or if you use it on the patient mouth. The best fit between the library and the scan body that you acquire on your model. So, digital solution, different T-based solution, depends on the soft tissue thickness, again, to realize a screw monolithic restoration for your final rehabilitation. And again, platform switching concept, the same for the T-based abutment, that really helps you to better increase a nice soft tissue around your implant, better cleanability, and better stability of the level of the bone. So the same platform switching concept. 5 years follow-up. So just I would like to show you how this new technology can really help your dental daily practice. And there is only one information that you have to take care. Scan body, you have a part that is the scan part that you have to take care how to scan with the intraoral scanner. And then help you in different situations. Nowadays, with the intraoral scanner, became more and more performant. And we have the possibility to take an impression even if the implants are not all parallels between them, in a very easy and accurate way, even if you have a full edentulous patient or a partial edentulous patient. Accuracy became higher also for the occlusion point of view. And again, monolithic screw retain restoration for our final restoration. Then, for who has the CEREC approach, again, B&B Dental has the CEREC base that you can use it with a scan post to perform in a chairside environment. You only know that you have a gray cap for the intraoral acquisition and the white cap for the laboratory acquisition. Then you can perform on a post-extractive solution. Then you can take an impression immediately and obtain your provisional implant support restoration, immediate loading protocol, immediately after the implant positioning. So the protocol is always the same. Digital impression or traditional impression, CAD design to create and to identify the scan body head. Once the scan body head is confirmed, then you can create and design your final rehabilitation or your provisional rehabilitation in order to obtain your prosthetic solution. Then you can go with a chairside workflow, or you can go with a milling center or your dental technician. But let's move on and let's see how the guided surgery, B&B Dental guided surgery workflow works. And let's consider how the introduction of this new technology can change also our surgical way of thinking and working. Thanks to the introduction, as I said, of the CBCT, we have the possibility to acquire data in a more accurate way. That means we have the DICOM data files from the CBCT that can be used in a computer monitor on a software to create a virtual model of our patient. Then, thanks to these softwares, now we can plan better our implant in according with the bone anatomy and in according also with the final prosthetic shape of our future rehabilitation. So, as for a definition of the guided surgery workflow, is that the guided surgery is a surgical template made after a 3D virtual implant planning. So it's a way to place our implant in a more predictable and precise way. From the 3D virtual planning, designing our 3D surgical template, and the guided surgery approach. So why we should change our way of thinking? There are many advantages of this protocol. First of all, today our patient asks us to be less invasive, to do less steps, surgical steps, maybe less money, and to have the possibility to avoid a removal prosthesis during the whole treatment time. So by using guided surgery protocol, we can perform a less invasive surgery, avoid large mucoperiosteal flap, so we can be less invasive. In some cases, we can perform flapless surgery, and we will see that not in all cases we can perform flapless surgery. That means less pain and discomfort for our patient. And of course, we can perform an immediate loading protocol by delivering a provisional restoration immediately after the surgery. Then, which kind of guided surgery protocols we have? We have different solutions. For example, we can perform for a partial edentulous patient. We can use a teeth support guided surgery protocol. We can use a mucosal support, and this is for the flapless surgical approach. Bone support. Sometimes when we have not enough quantity of bone, I open the flap, even if I use the guided surgery protocol. So we also can use the guided surgery protocol with open flap technique or mixed support. Anytime when it's possible, maintaining some teeth means stabilize the guided surgery during the surgical drilling protocol. So the fact that many articles come out with the guided surgery aspect is the accuracy. The accuracy means matching the virtual planification of our implant with the real position of our implant after the guided surgery protocol. So many articles consider that the tooth-supported renders highest accuracy, single highest precision. The problem is the presence of the keratinoid Z mucosa and the bone ridge anatomy. For a flapless approach, these two considerations are mandatory to perform a guided surgery approach. Another contraindication, let's say, limits of the guided surgery protocol are the limited mouth opening or the metal artifact. But we will see how we can avoid these limits, the metal artifact, of course, because the limited mouth opening of the patient is the real contraindication of the guided surgery protocol. So, as I said, the accuracy is the main concern about the guided surgery protocol. And it's important to understand that in order to be more accurate possible from the beginning to the end, there are many steps that you have to take care to perform in a proper way in order to avoid some errors that can be involved in this guided surgery protocol. There can be errors, for example, from the CBCT, for the matching of the files. There can be errors, for example, from the scattering effect, if your patient has some metal prosthesis in his mouth. There can be some errors of the fabrication. So all these steps that are involved in a guided surgery protocol should be done in a proper way in order to increase the accuracy of the protocol. How we can avoid and increase the accuracy? We can increase it by planning properly. Planning properly virtually our implant planification means staying in a safety zone during our implant planification. That means around 1.5 2 millimeter. So let's see which is B&B Dental guided surgery workflow. And we can say that we need these two types of files. We need to acquire the DICOM data files from the CBCT acquisition. Then we overlap this file with the SATL files. These SATL files, as I said, we can obtain for the patient mouth directly with the intraoral scanner, or from the dental technician scanner. And this is based on a traditional WhatsApp or a digital WhatsApp. So SATL files and DICOM data files can be matched together, and has to be matched together in a proper way, overlap, and create a 3D virtual model of the patient, where now we can start to plan properly our implant in according with the bone and with the provisional shape of our restoration. Thanks to this information, now we can design our surgical template to guide our drilling protocol, design our provisional restoration to be ready before the surgery, and our 3D printed model with the digital analog inside. So the most important concern of guided surgery is the matching of these files. And when we have teeth, more than 6 teeth, this is possible. This matching is possible with the optical fusion by the dental elements. When we have a partial edentulous patient or a complete edentulous patient, this matching can be done with a radiological template, has to be done with a radiological template with some radiopack markers in order to create this matching. If the patient, for example, has metal artifacts in the patient mouth or is a edentulous patient, we also can use, for example, an extraoral markers. For example, these are Evobite, in order to be sure to match these two files in a proper way. So, let's see how to use the guided implant protocols. So we can use the guided surgery protocol in a complete way, or we can use it only for the diagnostic point of view. So we can plan virtually our surgery and then go by freehand, or a template assisted. Like in this case, we can create a guided surgery that will guide only the preparation of our first drill, and then we can insert our implant by freehand. B&B Dental has also bone regeneration materials and collagen membrane that I very often use in different situations. This is the second stage surgery. I always, especially mandible, increase the soft tissue augmentation in order to obtain a nice soft tissue integration. Thanks also to the transmucosal screw, healing screw in PEEK, I can obtain nice soft tissue integration around my implant that is mandatory for a better cleaning of the patient in time, especially in the lower jaw of the mandible, and this is before and after soft tissue healing, and again, the final restoration. But let's see, a full digital guided surgery protocol, we can use it for single implant and also multiple implant. Why it's so easy to use a guided surgery even for one single implant? Because having a digital impression, we can obtain these SATL files, we can match with the CBCT information, design by ourselves a digital WhatsApp of my future crown, and plan properly prosthetically guided implant solution. That means I can obtain a screw-retained monolithic restoration in one shot, avoiding the model. So using guided surgery even for one single case helps you to perform a better implantology. Better even because in cases like this I can offer to my patient a flapless approach. And this is also, as you want to know, to say to your patient, it's like a marketing. If I can to avoid to open the flap for one single implant, two single implant, this is better also for the patient. And then, one single case, flapless approach, guided surgery protocol, then you can take immediately a digital impression, or you can wait the implant osseointegration, again with a transmucosal screw peak. Then after 3 months, you can take the impression, or immediately after the guided surgery protocol. Sometimes I enjoy myself to create this customized healing screw in order to guide even better the soft tissue healing, especially in the posterior area. And then the workflow is always the same. Digital workflow, 2 appointments, one for the guided surgery protocol, the second for the implant intraoral scanner impression or traditional impression, and then delivery of the final restoration. More than this, so this was in the posterior area. Let's see in the frontal area that, especially in this case, what is mandatory to place an implant properly in order to be sure to obtain a nice aesthetic result, like in this case, we have different options to perform in a post-extractive area. And thanks to the CBCT, I can even collect more information, diagnostic information, like in this case, I had a big reabsorption, palatal reabsorption, and I can see the difficulty of the position of the root of this tooth that I'm going to extract. So, thanks with the CBCT, thanks to the intraoral scanning acquisition, I have the possibility to match these files and to plan properly my implant in a proper palatal position in order to perform also a prosthetically driven implant position to obtain a screw retain restoration with a posterior palatal whole axis screw. So again, in this case, because the patient asked me to maintain the diastema, I used the socket seal technique. So I maintain the vestibular, the buccal part and the mesial part of the root anatomy in order to maintain the soft tissue thickness on the buccal aspect, but also to maintain the level of the papilla. Then I perform a guided surgery approach. With the guided surgery approach, I can place my implant properly, but also I can deliver a provisional restoration with a nice contour, with a strong S-line, because I keep the portion of the root on the buccal aspect, and perform and deliver the provisional restoration immediately after the surgery. This provisional restoration was done thanks to my 3D virtual implant planification. Was ready before the surgery. This is the provisional restoration. After 5 months, I can copy with a digital impression not only the shape of my provisional restoration, the soft tissue contour, thanks that I can duplicate and copy the provisional restoration contour, and I can send everything to my dental technician that can duplicate the shape of my provisional restoration and create the final restoration. So even for simple cases like this, having this kind of protocol really helps you to increase the diagnostic approach, better plan, more precise, obtain a prefabricated provisional restoration before the surgery, and perform an immediate loading protocol. As is the same also, for example, partial edentulous patient. This patient has a phobia of the impression, phobia of everything. So which kind of solution I have to offer to her? So in this case, the same. I plan a 3D virtual implant planification. I perform a guided surgery protocol that then immediately after the guided surgery protocol, I take the impression with a scan body, sent to my dental technician that can create my final restoration, and really with only 2 appointments, I deliver the final restoration, screw retain restoration, and this is the final restoration in only 2 appointments with a predictable approach. With the virtual planification, we really can plan better our implant. Even if we are good surgeon and we are capable to place our implant properly, very often in difficult patient situation, we have the possibility with the guided surgery to plan prosthetically correctly our implant and obtain our prosthetics rehabilitation, screw retain, and avoid cemented restoration in order to avoid the cementation. And this was for single cases or multiple cases, let's say. Our daily routine. This was our daily routine. How can we start to think digital in our daily routine? Let's see for more complex cases. How can we control in patients like this that arrive in our clinic, how can we control the fear and the pain during our surgical session? And the important for the guided surgery approach is understand where it's possible to do it. So the case selection, especially in a dental loss patient, especially in patient with a challenging bone anatomy, it's mandatory to understand and to choose properly the case. And which are the points that we have to take care? One is the bone quantity and the quality. The second is the soft tissue thickness. If we don't have keratinized mucosa, very often in the mandible it's difficult to have keratinized mucosa, it's better to open a flap. Then we can also perform a guided surgery approach. If we need a bone reduction, we need to use a double guided surgery protocol. So let's see a case, in a dental loss patient case, for example, how we can perform a guided surgery protocol. As I said, it's important to obtain the radiological template, how to match the files for the CBCT files information and from the SATL files information. And this is necessary to obtain it with a radiological template. And the protocol is always the same. But for the dental loss patient, we can have also another protocol that is a double CBCT technique. That means that we also can scan the patient prosthesis device. So we can take a CBCT scan from the patient, take a CBCT scan from the prosthetic device, and match and overlap these 2 DICOM files in order to obtain and to create our 3D virtual patient and plan properly our implant. So, as I said, for a dental loss patient, we can have different options to match these files. We can match it with the markers that can be glued on the previous provisional or full restoration of the patient, or we can duplicate the removal prosthesis and glued these radiopaque markers, or we can use the extraoral markers. The point is always be sure that the matching is done in a proper way in order to start to plan properly your implant in a full arch rehabilitation. Consider the inclination, the parallelism, the force occlusion, the distribution of your implant. But this is also important, as I said, and I will always try to make you understand that the file matching between the STL files and the DICOM files are mandatory to increase the accuracy of the guided surgery protocol. We also, with the 3D implant planning software, we have the possibility to decide everything in advance, because we have the possibility to choose in the library which kind of multi-unit abutment we need, which is the height of the multi-unit based on the soft tissue thicknesses, which is the inclination of our implant, in order to plan properly and obtain a proper provisional restoration. Based on our virtual planification, then we can design our surgical template. And at the day of the surgery, we will receive not only the surgical template that will guide our drilling protocol, we will receive the 3D implant, the 3D model with the analog, digital analog inside, the provisional restoration reinforced before the surgery. And these are the important features of the B&B Dental guided surgery technique. B&B Dental use sleeves in peak. The sleeves guide the drilling protocol during the guided surgery protocol. The particularity of the peak material is that, especially in the guided surgery protocol, not overheat the bone. That means that, respect of the metal sleeves, we can have an auto-lubricating. The water can go inside easily. Low friction means more precise protocol. Low friction means that we have a tolerance between the drills and the sleeves. And this tolerance with the peak sleeves should be less, because we don't have the friction. And this tolerance is 0.02. So this was the choice of the B&B Dental that increased the accuracy and also decreased the overheating of the protocol. Then another important factor is that we also can use the open sleeves if we want to perform a guided surgery in the posterior area. There are different small and big sleeves, depend on the implant diameter that we choose. Then another important feature of the B&B Dental guided protocol is that they also has some crystal pin. So in order to increase the accuracy of the protocol, we have to be sure that our surgical template is well stabilized during the drilling protocol. And this can be done with the lateral pin, anchor pin, but also with the crystal pin that B&B Dental has in their kit, in order to avoid movement of the surgical template. And again, a predictable drilling protocol that has to be followed in the proper way increase also the accuracy of the protocol. So, as I said, in cases where we have enough bone, we have a keratinized mucosa, we can perform a flapless approach, especially in patient, very old patient with, for example, medical disease. Performing a flapless approach, it's also a good way for doing less invasive surgery and offer them a good opportunity to give them something fixed. Perform a guided surgery protocol means less time also for the patient, and also have the possibility to deliver the provisional restoration immediately after the surgery. Then we can use also flapless or in also post-extractive cases or mixed approach. As I said, what we receive at the day of the surgery is not only the surgical template, but also the 3D printed model with the analog inside, with the multi-unit abutment that we have already decided on the virtual planification, and our provisional restoration that is reinforced with a metal bar or a PIC bar that we can rebase on the patient mouth immediately after the surgery. We can also use the B&B Dental compactors, also for the guided surgery protocol, in cases if you want to perform a post-extractive cases, or in cases where you have a very thin bone ridge anatomy. So again, prosthetic solutions that were previously digitally planned avoid you to have a much necessity of a big magazine, because you know already what you need after the surgery. So multi-unit solution, titanium cylinder, on the top, then you can rebase your provisional restoration immediately after the surgery. Then you can have also different solutions like flat abutment for the small diameter implant. So guided surgery protocol increase the predictability of your surgery, but also decrease the invasivity and give the possibility to deliver provisional restoration, functional and aesthetic for your patient. So I want to just give you some take-home message that this digital technology, this digital revolution really give you some real opportunity. First of all, minimize the treatment planning errors, because you can make a proper diagnosis and start to plan with a better approach from the beginning, virtually. You can plan your implant position having in mind your future prosthetic design, and you can also minimize the surgical and prosthetic errors. Of course, each step in this guided surgery workflow should be done in a proper way. As far for the patient, we can decrease the number of the surgical procedure, only one surgery. We can also perform guided surgery approach, and then in case is necessary, we can also perform bone augmentation after the guided surgery protocol. Decrease the treatment time for us, but also for the patient. Avoid removal or removable prosthesis. Increase the patient comfort and acceptance, because this is why more and more the patient asks us. Of course, increase the soft tissue contour preservation, because we can guide also the soft tissue contour with our provisional restoration. So, in the end, what I would like to say that the digital dentistry give us a real opportunity to better plan, but also to better do our daily routine, but also we are still the brain. So we have to guide this new technology with our traditional skills. So everything is based on our traditional skills. And I know that most of you know this patient that I showed you 3 years ago in the first B&B Dental meeting. And I just want to share with you, this is 5 years follow-up of the 2 guided surgery protocol, upper jaw and lower jaw. And at the end, I just want to show you where we can go with a digital protocol. Now, thanks also with the digital apps, we can perform a digital diagnostic treatment plan, use a digital smile design, start planning in advance on a computer monitor, perform a guided surgery protocol, and then print everything. Because thanks with this new technology, now we can print our provisional restoration, we can print our radiological template. Then we can combine all this information also with a face scanner to be more predictable for the prosthetic point of view, and combine everything and obtain at the day of the surgery even more accuracy and more aesthetic outcome of our final restoration, and more accuracy. And at least for the guided surgery protocol, what we are doing now is creating groups of colleagues like me that we are trying to understand the real accuracy of this protocol. And this is amazing to see that after a guided surgery protocol, we really can obtain a higher accuracy between the virtual implant planification and the real implant position, of course, keeping in mind that all the steps should be done in the proper way. And for example, in this full arch rehabilitation, we obtain some discrepancy around 2 degrees. 2 degrees is very, very, very low. That means that we really can obtain a good accuracy with the guided surgery protocol. And also, keeping in mind that also we have to manage the soft tissue, as I said at the beginning, for a better preservation in time of our work, and of course for the better acceptance of our patient. So the last take-home message is that with the traditional approach, we had to open the flap in order to see what we are doing. With the guided surgery, we can open the flap, but it's not necessary to open such a big flap because we already plan our implant position. We can perform an immediate loading protocol with the guided surgery protocol. With the traditional workflow, we had to take an impression immediately after the implant position. That means that we have blood, then we have to send the patient home, and then deliver the provisional restoration after 1 day. With the guided surgery protocol, we can deliver the provisional restoration immediately after the surgery. So, in conclusion, the digital approach can increase really our daily routine by giving us some real benefits. That is faster communication with the patient, with our dental technician, reduced time for us and for the patient, easier data storage because now we can use the iCloud, more patient comfort, better diagnosis. Of course, at the beginning, as I said, we need to invest in this digital equipment. We need company like B&B Dental, that is a family company, that they really try to stay updated day by day to introduce what is new in the digital technology, to stay updated with the software, to stay updated with the prosthesis solution components that is changing day by day. So we need a learning curve that is necessary, like when we start to use our iPhone. We need to know how to use the iPhone. It's the same with the digital technology in our daily routine. And we have to invest also money to stay updating with all this technology. So I hope that I describe everything from the prosthetic point of view, surgical point of view of the B&B Dental solution. So thank you for your attention. And thank to my girls for their acceptance. Thank you.
We would like to give Ioana this gift.
Thank you.
As a part of our gratitude for her work that she has been done with us. So to allow her being in contact with us more.
Thank you.
And in this case, you'll need a learn curve also on this new device.
Okay, I will.
So I would like to thank also Ioana. She was one of the first lecture to start with us, to start lecturing all around the world. I think we visit more than 10 countries, giving lecturing all over the world. So special thanks to her for all the job done in all these years. Thank you, Ioana.
Thank you. Ioana.